May I request all the delegates to come to the first line of the row so that we can have more of interactions and eye-to-eye discussions today. Hi, it's my honor and pleasure to invite our speakers of this instruction course, Dr. Vikas Menon from Aravind Eye Hospital, Chennai, and Dr. Seema Das from Shroff's Charity Eye Care, Delhi. May I request you to come up on the podium? And this instruction course has been running for many, many years, and it's a star course of AIOS, well curated and introduced by Dr. Santosh Hunavar. He's a secretary of AIOS, and he has been busy running around organizing the entire conference, and we are expecting him here soon. May I request Dr. Vikas and Dr. Seema to please come up on the dais, and Dr. Rolika, please.
So welcome everyone, and we will start our first talk with Dr. Feroz, and she'll be talking to us on epithelial and stromal tumors of the ocular surface. So over to you, Dr. Feroz. So today we will be covering the entire spectrum of the tumors of the ocular surface. And we start with Dr. Feroz, who will be talking on the epithelial tumors. Then Dr. Vikas Menon will be talking about the pigmented tumors of the ocular surface. And Dr. Seema Das will be telling us about the congenital lesions of the ocular surface and the surface tumors. And Dr. Hunavar will be talking about the overall management. And I'll be taking the interactive case presentations. I've requested the AV team to provide us hand mics, so this is going to be entirely interactive. There will be cases coming up, and I request all of you to try guessing the cases. Over to you, Dr. Feroz.
Thank you, Rolika. So, well, it's always been a pleasure and honor to be part of such a nice instruction course, and well, we're all tumor lovers over here, and tumor means tumor of the eyelid, the ocular surface, and I think ocular surface tumors are more important as far as a conference like AIOC is concerned, because it covers a whole spectrum which would be useful for a specialist in ocular oncology, anterior segment surgeons, as well as a general ophthalmologist. And that's exactly what the vision of this particular instruction course is. And I'm going to take you through the tumors of ocular surface, epithelial and stromal tumors. These are my affiliations, and these are my financial disclosures. So, well, tumors comes in different colors, they comes in different shapes. Well, conjunctival tumors, to be honest, it's not too difficult to diagnose, because every tumor comes with a clue in the color. Every tumor comes in the clue of the shade and the location in the ocular surface. And it's obviously one of the cancers of the eye that is readily visible for your naked eye. You just need to pick up what is important to differentiate between a benign and a malignant lesion. So the objective of my talk here today is clinical diagnosis and differentiating features, where management will be covered by Dr. Hunavar. Now, going on to the classification, as I'm going to deal with epithelial tumors and stromal tumors, well, epithelial tumors again are classified as non-melanocytic and melanocytic. I'm not going to touch upon melanocytic because Dr. Vikas Menon is going to give you an extensive talk on that. Stromal tumors can be vascular, it can be fibrous, depending upon, where it arises from anatomically: histiocytic, myogenic, lipomatous, and lymphoproliferative. Then we have a very important location in the eye, which is caruncle, which has got all the structures. You can have squamous epithelium, you have sebaceous glands, you have hair follicles, and there are particular tumors, although rare, arises from the caruncle. metastasis, secondary tumors, and congenital tumors. We did publish about tumors of ocular surface a large review, and well, it is available in IGO. When we talk about ocular tumors, what is very important as a practicing clinician is to differentiate between benign and malignant. Well, we are concerned about malignant. We want to reduce the recurrence, and we want an excellent outcome for these patients as far as vision salvage, eye salvage, and life salvage is concerned. So I'll take you through few cases which will give us an overview. It's totally case-based. Certain cases which I learned, and I'm gonna share my experience with you. Now, very basic, we know that benign and malignant, there are certain characteristic features which differentiates each. Age of onset, progression, whether it's recent or long-standing. For example, if it's a recent, rapidly progressive lesion, be it in any part of the body, it probably is a malignancy. Symptoms, location, surface, vascularity. Now, vascularity and feeder vessels, I would combine it together, and that actually is the biggest clue in differentiating a benign from a malignant lesion, because we all know for a tumor to grow to its size rapidly, it needs oxygen. For oxygen, it needs blood, and for blood, it needs these large vessels, and these are called the feeder vessels. Well, I want to keep it as an interactive, but Rolika is doing an interactive down there, but just tell me like which one do you think is a malignant lesion here? You have one in your left and your right. At least tell me how many out of the 6. 3 is malignant, perfect. Can you tell me which one, right or left? This one? This is what? Malignant? Perfect. This one? Malignant? Perfect. This one? Yeah? Plus or minus, yeah. And what you see here is the fierce redness in them, right? It's completely vascular. There is large feeder vessels. And that's how you differentiate between both. In fact, yeah, this is a cyst, this is a pterygium, and this is a myocysticcercosis over here. All right? We'll come to the other diagnosis in subsequent slides. Well, easy, 72-year-old gentleman, gradually progressive mass, 1 year. In fact, he had previous surgeries done multiple times. He was referred query lymphoma to me. Well, it looks fleshy. It really looks fleshy. There is surface vessels over there. It's arising from the fornix. But this particular test of a transillumination gives away that it is a cyst. So it was an inclusion cyst with a history. So history is also very important, that he has undergone multiple conjunctival ocular surface reconstructive surgeries in the past, and it's from that he developed an inclusion cyst. Now, here this lady presenting with a lesion in a left eye in the temporal bulbar conjunctiva, in a right eye temporal bulbar conjunctiva. Let me show you, yeah. So this is what she has. This is cystic indeed, right? She doesn't have a history of surgery. She says it has been present there since childhood. This is slightly cystic, but more of fleshy, right? Asymmetric, both eyes. And she says, well, it has been there since a long time. If anyone can shout out the diagnosis, I'll be very happy. Otherwise, I'll proceed. Shifali, you're not telling the answer. Yeah, does it look like a cyst, like an inclusion cyst? What can be that conjunctival lesion with some amount of scattered pigmentation, childhood, which can be cystic? Yeah, Shruti? Nevus, right? Yeah. So this is, well, all nevus has microcyst, some has macrocyst, and some has balloon cyst. Okay, so this is basically a balloon cystic nevus of this eye, and well, nevus need not be always melanocytic. I'm sure Dr. Vikas is going to take you through a lot of pigmented lesions. So if they have some amount of scattered pigmentation, we have something called a amelanotic nevus. We also have something called amelanotic melanoma of the conjunctiva. So all nevus need not be, but well, you know, the cyst, the microcyst and the macrocyst in a pigmented lesion or query scattered pigmented lesion always gives away as a conjunctival nevus. This was a very interesting case. This was a Chinese patient of mine, young girl, 32-year-old, who was diagnosed as chemosis, like, you know, long-standing chemosis, punctures done, still it's not going away. It's transparent, right? And it's compressible. Cysts are usually not compressible. It's like, tenons underneath, it's pretty tight. So this is the lesion there. Pretty rare. So, it was during that time that a series of this particular tumor was published, and I thought probably it could be that, and excised it, and it's a conjunctival stromal tumor. It's called coast, something which is very similar in terms of a coast which is transparent and fleshy inside is myxoma. So conjunctival myxoma can be associated with cardiac myxoma. Well, there is no direct association of a coast to cardiac myxoma, but when a patient comes with coast, we still evaluate them cardiologically with a cardiologist in order to rule out a cardiac myxoma. Very straightforward case, 2-year-old child, spot in the eye since birth. It is limbal dermoid. All right, yeah. Now, 32-year-old lady, eyelid swelling and fleshy mass, both eyes, childhood that she says. You can see some amount of fullness in the upper eyelid laterally, looking like a lacrimal gland swelling. Lower eyelid, more fullness in the other eye, taking you through. So this is what she has, all right? This fleshy lesion over here, fleshy lesion inferior, fleshy lesion in the other eye. What could it be? What do you see there? Here, some amount of dermal appendage. This is actually a hair which is coming out, okay? Dermolipoma, right? So we have been taught in our textbook that most of the dermolipoma, all of the dermolipoma in our teaching, that it's in the superotemporal fornix, right? Need not. We always thought it's unilateral and unifocal, but it can be bilateral, it can be multifocal. What gives away is this particular yellowish color appearance. There is a hair, 2 hair coming out over there, there is a follicle over there, and this gives away the diagnosis. So this is a dermolipoma, multiple bilateral. All right, yeah. Well, straight away case. Yeah, reddish lesion. So anything which is red. So now we came from yellowish, whitish, now we go on to the reddish, okay? Straightforward, this is a capillary hemangioma, right? You can have small capillary hemangiomas, you can have big capillary hemangiomas. Now what is this? It's again red in color, but it has also got violet in color. It's a shade of reddish color there. A little bit, nicer in between, and then comes another reddish layer. Venolymphatic malformation, Shruti, right, yeah. So this is the entire lesion, including the caruncle and then extending into the bulbar conjunctiva. So this is a venolymphatic malformation. Anything red, we always think of vascular, and most of the time we are right. All right, this is also venolymphatic malformation, an extensive venolymphatic malformation where it was an orbitoconjunctival venolymphatic malformation, even involving the frontal sinus, where initially she was actually operated by a neurosurgeon. All right, for the conjunctival. This is how patients reach different specialities where they really don't know that there is a specialty called ocular oncology who can deal with all tumors of the eye in and around. Well, and she had repeated, it was excised before. Well, we all know that venolymphatic malformation, how much ever you excise, it's gonna be there, right? Yeah. So conjunctival orbital sinus venolymphatic malformation, this is the frontal sinus portion that I am showing with the arrow. The only thing that I did, I was not a magician. Patient thought I had like a magic hand, no, we all know what really works. You don't need to go and do an extensive surgery in this case. This is a magic drug. We are happy and blessed. And she has this ptosis because of the previous neurosurgery that was done in her, including the sinus. And this is all that was done, including the sinus, and she did well. She got married. Well, this is another case, again a reddish lesion, okay? We have the ISSVA classification of vascular tumors and vascular lesions. So I'm just showing you a spectrum of these reddish lesions. Well, any diagnosis over here? She has been operated twice before, and then it again balloons up elsewhere, and then they said that, can you do something? So Anything? Is it venolymphatic malformation? Is it capillary hemangioma? Doesn't look like, right? It's like really purplish. Yeah, more of venous blood? Venous blood, right? Yeah. So this was a venous malformation. In fact, this patient had venous malformation which was connecting to the cavernous sinus. Well, after counseling the patient, I still went ahead with bleomycin. Yeah, I was careful because when I sent her to the neurointerventional radiologist, he told me if I have to clip those tiny extension into the cavernous sinus, she might require 75 to 100 clips, which is difficult. So then, I took a little bit of risk there, but it really worked, injecting it anterior, and bleomycin worked for her. Pyogenic granuloma, we all know, it is a misnomer. It can come from a scarring after your OSSN excision biopsy. With an AMG, you can have a pyogenic granuloma. It is a hyperproliferation of the tissue with vascularity, and this was the same. Conjunctival papilloma. So usually OSSN is the differential diagnosis of papilloma. OSSN arises from the limbal area. There will be some amount of limbal origin, but this is way away from the limbus, something like OSSN. Always think of conjunctival papilloma, and this patient was an immunosuppressed patient with HIV. 37-year-old, reddish lesion. She comes with recurrent subconjunctival hemorrhage in the left eye, past 2 months, up and down. There is no vascular lesion. Sometimes a venolymphatic malformation can bleed. It can be transparent, then it bleeds, But this was something very different. Yeah, it doesn't have any purplish look. It's some kind of a yellowish look, but there is a recurrent bleed. Anju knows the answer. Lymphangiectasia is one of the diagnoses, yes. Anything else? Awesome. So this was subconjunctival hemorrhage, and these are the things that we usually think of: venolymphatic malformation, amyloidosis, and the worst, Kaposi sarcoma. This was amyloidosis, and this was primary and localized. This one, now we come to the white. This was in fact referred to me, query case of sebaceous gland carcinoma. Sebaceous gland carcinoma cannot be white, it's usually yellow. So, well, since it was referred and I don't want to make a mistake, I said, well, you were going for an excision biopsy, just limit it, not the wide margin excision, and if something comes out, we will treat further. And this was a keratin cyst. All right, yeah. Yeah, same. Now, coming to a little bit of pinkish, yeah. Stromal, extending from here all the way up here. Sorry? Louder? What is it? Benign reactive hyperplasia. Well, that usually is in the limbal area. It's a differential diagnosis of an OSSN, yeah. Well, this is kind of very irregular surface, right? When you see something like this, a salmonish, the thing that you think of is a lymphoma, but lymphoma has that particular feeder vessels which comes from somewhere and just dips inside. There is a prominent vessel in lymphoma. It doesn't have that, right? This was also a case of primary local amyloidosis. So we have a big series now. I don't know how these things, I attract amyloidosis, I really don't know. We have a large series. I think we have been seeing one after the other every month. And this is a varied presentation of amyloidosis. And I think probably our eyes doesn't see what our mind doesn't know. And these are the presentation. This was just a small, query SGC, concretion, and I just did a biopsy, and this came out to be a amyloidosis. Extensive. This was very, very extensive, where the patient presented with ptosis. 50-year-old lady, referred for a mass, both eye, recent onset. She had a fullness over here. Query, fat prolapse. Well, it really doesn't look like a fat prolapse, right? Fat prolapse is yellowish. This is again salmonish, and you can find that feeder vessel, right? Dot on. The other eye also. So it was multiple muscles affected bilaterally. The only thing that I did, I just went and did along the muscle. In fact, yeah, I went for an imaging. This is the imaging over here where the muscle is involved. So ocular surface need not be only ocular surface stromal tumors. It can be a muscle, a lateral rectus or medial rectus where there is an infiltration with lymphoproliferative lesion. which is involved. And yeah, I just did a biopsy along the muscle, not cutting it vertically but horizontally, and it came out to be a non-Hodgkin's lymphoma, extramarginal zone, low grade. This is how we evaluate them. Now, 56-year-old lady, frequent redness, bilateral. She's been on and off steroids and on and off lubricant eye drops, and these are the lesions that she has. And this was also a case of Malt lymphoma. So lymphoma can be this tiny as well. That's now 70-year-old gentleman, whitish lesion, right eye. Can I take 2 minutes? 2 minutes, yeah. Right eye, 4 months, very classical keratin feeder vessels, right? Straightforward case, OSSN, and it arises from the limbus. Now, we have ocular surface squamous neoplasia as a spectrum, dysplasia, carcinoma in situ, squamous cell carcinoma. Well, we need to differentiate between them. And why is it important? That OSSN in insequential pterygium specimen, it's reported as high as 10%, and OSSN coexistent with pterygium is almost 2%. So, well, whenever there is a suspicion, it's good to send your pterygium specimen for histopathology. SCC is important because it's the most common conjunctival malignancy, and aggressive variants like mucoepidermoid spindle cell and adenocarcinoma is present. Clinical diagnosis is perilimbal location, keratin, rose bengal staining, feeder vessels, intrinsic vessels, corneal encroachment, and scleral fixity. Scleral fixity, of course, you can do AIOS2025 stuff, but in the presence of keratin, it's very difficult because there will be a lot of backscattering. So this is a very simple test using a cotton bud, whether it is fixed or not. Now, risk factors, as you all know, xeroderma pigmentosum. This was a child presenting as early in her 7 years of age, papillon lephor, which is very, very rare, immunosuppression and UVB rays. This is a kind of a papillary OSSN, which simulates a papilloma, conjunctival papilloma. But then, well, this is a feeder vessel, which is very, very different from a papilloma. This definitely looks like a small nodule, very, very small nodule, but it's the aggressive variant of an SCC, squamous cell carcinoma of the conjunctiva, which is mucoepidermoid. Well, cornea, easy, we take AIOS-OCT, and this is a very classical presentation of a pouting of the epithelium and thickening of the epithelium that you get in a corneal OSSN. Diffuse corneal OSSN in an immunocompromised patient, which was in fact treated as various other corneal erosive disease, but it was a case of OSSN. Necrotizing scleritis is yet another presentation in advanced OSSN. It can be pigmented, known as pigmented OSSN, not a nevus, but you have this surface keratin over the pigmentation, which makes it a pigmented OSSN. Clinical documentation is very, very important. Before we take these patients in for surgery, we actually just not delineate the elevated nodular area, but also the congested thickening of the conjunctiva, and 4 millimeters from either side will be our excision. Ultrasound B scan for intraocular extension and orbital imaging in case of orbital extension, especially if it is in the caruncle and the fornices. Caruncular tumors, quick takeover here. Oncocytoma, I just saw one case in my whole 12 years and 13 years of my practice. Very, very rare, but these are the lesions that you should be keeping in mind in the caruncular lesion. Sebaceous gland hyperplasia, 68-year-old gentleman, redness, fiery red lesion. It could be a sebaceous gland carcinoma as well. Sebaceous gland carcinoma can present as a very asymmetric unilateral blepharoconjunctivitis, which is a pagetoid intraepithelial variant of a sebaceous gland carcinoma. One last quiz. Is it OSSN? Is it amyloidosis? Is it venolymphatic proliferation, venolymphatic malformation? Is it vascular lesion? What could it be? No, Shifali, sorry. Sorry? Excellent. You win a prize. It is extensive rhinosporidiosis of the conjunctiva. It was referred, query malignancy to me, a young guy. And, well, I treated him with complete excision, AMG, and cryotherapy. Yeah, thank you so much, and it's been a pleasure. I hope it was useful, and well, it is a wide clinical spectrum. Clinical diagnosis is very important to get dot on to plan further management. Thank you very, very much.
Thank you so much, Dr. Feroz. That was absolutely interesting. I do not think I need to give my talk at all. because Dr. Feroz has covered it all. Yes, I started changing my slides the moment she started. I was like, okay, we need something different. And now we have Dr. Vikas Menon with us, and he'll be talking on pigmented tumors of the ocular surface. May I request Dr. Honavar to please join us on the stage, as it suits him.
Good afternoon, everyone.
Dr. Santosh
So,
is the chair of the
from the
instruction
whites
course.
and the pinks and the reds, now we move on to the black. Now, normally we have in the conjunctival anatomy, as a normal conjunctival anatomy, we have a lot of melanocytes as in the basal layer of epithelium, but they are far outnumbered by the epithelial cells. So that's why you don't see pigmentation as prominent. But then there are situations where either the pigment production is increased by these melanocytes or there is an abnormal proliferation of these melanocytes, and that is where you start seeing these pigment discolorations or various types of lesions. To understand about these pigmented lesions of the conjunctiva, it is best to try to think of them in either of these three categories, either benign, which are safe and the best types to have, which may be nevi or complexion associated melanosis or racial melanosis as it was called earlier, or there may be lesions which can have a significant risk of progression to melanoma, and the number third is the malignant form, which is the melanoma. So whenever you see a pigmented lesion, the question that one needs to answer in mind is whether it's one of these three, or it's a safe one basically, or is it a dangerous one. So let us see a few examples of how we can differentiate one from the other clinically. Now, who will tell me what is this? This patient presented with a bilateral diffuse pigmentation of the bulbar conjunctiva, more concentrated around the limbus and extending up to the just short of fornicis on all sides. So anyone, what is this? What does this look like? Yeah, so this is complexion associated melanosis. So this is a absolutely benign condition. There is no risk of malignancy. It's very common in our country, and people who have a darkly pigmented skin, more often it is seen in them. What happens here is basically there is no proliferation of melanocytes most of the times, but there is increased pigment production from these melanocytes. You don't need to do anything about it, and they don't require any surgery or anything. Now, who will tell me what this is? Fairuz has already shown a few examples. Yes. So this is actually the most common form of conjunctival tumor in our population, and this is a benign one, fortunately. What you see here is a rather well-defined, slightly elevated pigmentish mass on the bulbar conjunctiva near the limbus, and there may be one or two feeder vessels, thin feeder vessels as you see here, and what you see here is the presence of these small tiny vacuoles or cysts within the substance of the lesion, and that tells you that this is a benign lesion and this is known as nevus. This is a slightly larger variety of nevus, and if you are able to do an AIOS2025-IC504-Tumors, you will be able to see the cysts more clearly, and if ever you are in doubt, you can resort to AIOS2025-IC504-Tumors, look at the cysts, and you will get to know that this is just a nevus. So management will be covered by Dr. Honavar later on. But these usually don't require anything except observation unless the patient wants a cosmetic removal. Typical locations of nevi are near the limbus on the bulbar conjunctiva, and even the plica or on the caruncle. It's normal to have them. It should not alarm you if you see a nevus on the caruncle. It's okay. Now, sometimes the parents of a child come that this was a spot that they were seeing for a long time, but now suddenly it has become darker, blackish, and little more red. So what to do? And you remove it, and what you find is an interesting variant of the nevus, that is the inflamed nevus. So it's still a nevus, but in children, especially if they are in the pubertal age group, it may get inflamed a little bit, or children who are more prone to allergic conjunctivitis or vernal spring catarrh, those are the cases where the nevi can get inflamed and you may have a sudden change in color, and slightly more reddish appearance or more vessels. Nothing to be alarmed about. You can counsel the parents, you can observe it, give some steroids, or if still the parents are concerned, there is no harm in removing it. Now this is one type of pigmented lesion which came with a large associated cyst, and as Dr. Fairouz had already shown you one example, this was a balloon cyst kind of a variant of nevus. Another variant of nevus which is rather less common in our population, but in western countries or in fair skinned people it can be seen, which is a patient presenting with a small pinkish or slightly yellowish type of a lesion on the bulbar conjunctiva. But what if you see typical cysts in that, that tells you again that it is a nevus and it's an amelanotic nevus. Not necessarily all nevi will be black. Remember that. Malignant transformation of a nevus is extremely rare, less than 1%. Now, if you see a nevus which has its onset in adulthood, there is a recent growth or color change and location other than bulbar conjunctiva, plica or caruncle, if there are prominent feeder vessels, if there is a recurrence after excision, so you should maybe reconsider your diagnosis and probably take these patients up for a biopsy. Now, this is a 60-year-old patient who presented with this diffuse extensive pigmentation of the bulbar conjunctiva for the last, growing steadily in size for the last 4 to 6 months. Anyone in the audience who can tell me what this is? Sorry? PAM, yes. So this is PAM, also known as primary acquired melanosis. As the name suggests, it's a primary pigmentation of the bulbar conjunctiva, meaning it's not secondary to any other cause like Addison's disease or drug induced or cosmetic induced. So it's a primary melanosis which is acquired, means it comes on later on in life and it's not present since birth. Usual age group at which it comes is the 5th or the 6th decade. You see it as a flat pigmentation of the conjunctiva which is relatively ill defined. The edges are not sharp as sometimes you may see in a nevus, and it's more flat. Now if it's on the bulbar conjunctiva, it's okay, and what you can map it properly, maybe observe it, or depending upon the extent you have to take biopsies. That will be covered later in detail. But if you see something like this lurking in the fornix, then you need to be more careful. You need to look at these patients with a little more cautious eye and not ignore this kind of pigmentation which is a recent onset, and you have this varied pigmentation in the fornix. I must biopsy these patients. This patient turned out to be PAM with atypia. Now, when you excise these lesions, the pathologist will tell you the information that you need. That is, the PAM can be of two types, either without atypia or with atypia. PAM without atypia has 0% chance of progressing to malignancy or melanoma, whereas PAM, if it is present with atypia, has almost 50% chance of progression to a melanoma. Again, in PAM with atypia, there can be high risk cases or low risk cases, and that helps you to decide your treatment about these lesions. Apart from fornices, if you see an acquired pigmentation on the tarsal conjunctiva or the palpebral conjunctiva, again that is a danger sign. So you need to be very careful. If you see this kind of an acquired pigmentation on any other site than the limbal or the bulbar interpalpebral conjunctiva, be a little more careful and have your threshold of biopsy lowered. For a very small lesion you can observe, but if it is larger than 2 clock hours, then you will have to intervene. So this is a histopath classification of PAM and risks of evolution into the conjunctival melanoma. As you can see in this chart, PAM without atypia is 0% risk to melanoma, PAM with atypia almost 46%, and then if the atypical melanocytes are located in other than basal layer of epithelium where they normally should be, then it's almost 90% risk of conversion to melanoma. And if they show epithelioid cell features, it's almost 75% risk of conversion to melanoma. So it can be pretty dangerous. So never ignore these lesions, elicit a proper history and look at the danger signs. This is how you properly map out these conjunctival lesions, especially those which are irregular, diffuse or multifocal ones. Now there are some clinical risk factors which you can keep in mind and which can tell you that this patient requires either a relatively closer observation or some intervention. If the patient with PAM is of an older age group, Male patients have been known to progress more to melanoma than females if the location is fornix or tarsus, greater diameter, greater thickness, feeder vessels, or an intrinsic vessels and hemorrhage. Now this lesion sometimes is confused with PAM, but if you look closely, the color is slightly different. It's not as brownish as you saw in the previous pictures. It's slightly grayish or bluish. Now why does that happen? Because this is not a conjunctival pigmentation. This is a benign lesion. This is a benign thing. It's scleral pigmentation actually, episcleral pigmentation. And in these cases, these will not progress to conjunctival melanoma, but you have to be careful, look at their dilated fundus. They may have malignant choroidal or uveal melanoma. That is more likely in these patients. So be cautious, and you also look at the palate in these patients, look at the hairline pigmentation, because they can have melanoma on other sites in the body as well. But they don't have conjunctival melanoma. This is not a conjunctival lesion. So it's important to differentiate between these two entities. This is an example of a secondary acquired melanosis, pigmentation in the fornix caused by chronic use of an eyeliner. So now this patient presented recently with a diffuse pigmentation of the inferior fornix, the medial fornix, and nodule formation in the upper fornix, dark pigmentation on lid eversion. It looks something like this. So what is this, PAM or what? Yeah. So if you notice carefully, what is happening is that this patient seems to be having PAM, which might have later on progressed to melanoma. So this is how it goes. So it starts as a PAM, but in many cases it will transform into melanoma at some stage. Now if one of us is seeing this patient at an early stage and we are able to pick out PAM, pick out the warning signs, and maybe excise the whole thing at an early stage, then maybe the patient would not land in a situation like this. Another patient, similar. What do you feel this is? So it has got a pigmented part, it has got a non-pigmented part. Thick, nodular. What does this look like? Exactly. So this is also another case of PAM converting to melanoma again. Another patient, similar. You have diffuse dark pigmentation of the fornix of the palpebral conjunctiva. Had these warning signs been tackled at an early stage, maybe patient's life would have been saved. This patient also had a large mass in the superior fornix when he presented. Again melanoma, patient died from metastasis. Another patient, look at this. So I can show you many examples, but what is important here to understand is that most of these cases of melanoma, as far as I have seen in my last so many years, they have all arisen from PAM. Very rarely they can arise from nevus, rarely, and extremely rarely that they arise without any primary predisposing risk factor. So as our ophthalmologist, and one of the purposes of having this IC over and over again every year is that we try to pick them up early on. None of us should make that mistake of missing out PAM at a stage where it is still manageable easily, and which can seriously affect the prognosis in terms of patient's life, because these melanomas are really dangerous. They have a high incidence of metastasis. So when we see a melanoma like this, again it's better to document it properly, and one of the ways is to go by the AJCC 8th edition classification, in which T1 is the tumor of the bulbar conjunctiva, T2 is tumors of the non-bulbar conjunctiva and tumors involving the caruncle, and T3 is any local invasion like into the globe, eyelids or orbit, and T4 is tumor of any size within CNS and henceforth. And as the grade grows, so does the mortality grows and prognosis worsens. Systemic metastasis, whenever we see in these patients, usually it is lymph nodes which get affected first, then the liver, lungs may be affected, and even brain has been known to get affected. Systemic metastases are fairly common. The reported incidence is about 26 to 40% for lymph nodes, and mortality in Western literature is 13 to 38%. But I'm not sure about the Indian data, but I'm sure if Indian data was compiled, then the mortality would be far higher, because the kind of patients we see here, they come to us at a pretty late stage. They come with a pretty massive involvement, And that is a time, by that time when they come to us, they already have some sort of micrometastasis sitting elsewhere. So coming towards the end, you need to differentiate these tumors from some masquerades. Dr. Fairuz again showed you an example. Now this looks like a pigmented lesion, but actually if you look carefully, there are patches of whitish keratin on this lesion, so which tells you that this may not be a melanoma, but the keratin part shows you that this is more like a squamous cell carcinoma, which may have pigmentation in our population, or a pigmented skin type person. Now this patient presented with a pigmented lesion with feeder vessels and some nodules also in that. So one of my main differentials was melanoma probably. And on excision I was pleasantly surprised. This was not a melanoma actually. This was again OSSN only. But what these nodules are, these are lymphoplasmacytic infiltrates. So you do get all these varieties. They mix. They can come in any shape and sizes. So wherever in doubt, better to do a biopsy. So in the end, to summarize, there are good, bad and ugly pigmented lesions. Nevi or complexion associated melanosis are the good ones. PAM, some of them can be good, some of them can be very bad, and melanoma is really ugly. So early identification is the key, because you want to avoid metastasis, you want to save the life of the patient at a stage where it is manageable. Once it grows into a full-blown melanoma, these patients have been known to come with metastasis even 5 years, even 7 years, 10 years down the line. So best is to avoid that stage. Thank you very much.
Thank you, Dr. Vikas Menon. It was an extensive clinical, I would say an album and great case. It was definitely a learning, and as he emphasized that, getting something right at the very early stage is so important for the final outcome as far as even life salvage is concerned. It's a pleasure and honor to invite our next speaker, Dr. Seema Das, who's again a well-known ocular oncologist that India has, and she practices in Shroff's Charity Eye Care in Delhi. And she has mentored many people worldwide, and it's great to have her here for the next topic on congenital lesions of ocular surface and other tumors. Over to you, Dr. Seema.
Thank you, Farouz. Thank you, Dr. Hanawar, for this opportunity. So I actually modified my presentation a little bit, quickly changed some few slides so that we can just recapitulate what Farouz has just taught everyone. So this is going to be more of an interactive, maybe some question and answers, so that we see how much we remember and just go through the whole thing all over again. So I'll be talking about some of the congenital tumors of the ocular surface and few other tumors and the different spectrums. So it's a huge list. The congenital lesions are mostly the choriostomas, different type of them. Vascular can be congenital. There are other lesions, some of those like the cystic lesions can be congenital. And then we have few other tumors. Some of these can be benign, some can be malignant. We have already gone through different type of presentation of the epibulbar choriostomas. They can be simple, they can be complex. So what is the diagnosis of this? We just saw some of the pictures. What do you think in this? Dermolipoma. So we know it's a dermolipoma. So dermolipoma, what is important to know, can have association, can have syndromic association. Both limbal dermoid and dermolipoma can be associated with the Goldenhar syndromes, and we know the features of the Goldenhar syndromes. So it's important to just look at the site profile of the patient also. If we find a patient having an epibulbar choriostoma, either a dermolipoma or a limbal dermoid. More often than not, dermolipomas sometimes tend to be isolated, but there can be syndromic associations. So what is important to know? Do you operate on all dermolipomas? If a patient comes to us, what is important to know when we are planning the surgical excision? These are surgical treatment. So what is important to know? Do you chase it? Do you go excising all of it? Because some of it is going to actually extend into the orbit, behind the fornix, most of the time along the sheath of the muscle, and some of them tend to be attached to the muscular sheath. Like for example, this is probably going to be attached to the lateral rectus sheath, and if you try to chase, we are going to end up causing so much of scarring in that area of the orbit, which is going to cause restriction of the ocular movements. So this is a cosmetic problem. We don't want to convert it into a functional problem of diplopia. So what's important to know is the excision indication is only for cosmetics purpose. We only do a very limited excision. We never chase it behind the fornix. Idea is to just make the area which is visible in the palpebral aperture clear and just leave behind the rest of the things. One more important thing, especially in the elderly age group, we have to differentiate it from the conjunctival fat prolapse or vital fat prolapse, which can sometimes mimic, especially if the patient is relatively younger. And we know the features of how to differentiate them. Just a small bit, we are talking about a limited excision. This is how we go about it. This was a syndromic patient with multiple conjunctival choriostoma along with the dermolipoma. So we try to find a plane between the conjunctiva, whatever healthy conjunctiva is there, usually they will be adherent to the conjunctiva. But since it's not a malignant tumor, we really don't have to chase and try to excise all of it. A debulking is enough. So we try to excise the part which is just in front of the muscle insertion and try to avoid damaging the sheath of the lateral rectus or any other muscle. If the overlying conjunctiva seems to be keratinized with a lot of hair follicles, sometimes those are the causes of irritation, ocular surface, watering and all, so that part can also be excised if required. Otherwise, we tend to conserve the conjunctiva as much as possible. So what are these? What about the first one? The second one is pretty obvious. It looks like a limbal dermoid. What about the first one? It's not really into the limbus. It seems to be into the cornea. So both of them are again dermoid. Some of them can be totally into the cornea, also not really into the limbus. The second one is the more typical one. Sometimes there can be chronic changes also. And sometimes there can be hair follicle keratinization of the surface, which can cause ocular surface irritation, and that sometimes is an indication for surgery in this patient. So usually we go about excision if there is any cosmetic problem, but again here we have to inform the patient, especially if there is a lot of corneal component, that scar on the cornea is going to remain. So there is going to be a white scar on the black part of the cornea, which they have to understand if the excision is purely done for cosmetic purpose. Otherwise, if there is an obscuration of the visual axis, there are findings like presence of hair follicles or keratinized surface, which can cause irritation of the ocular surface. We can go for excision. What about this? 15-year-old boy comes with this picture, and the mother says there is a lot of redness suddenly which has come up, and this lesion seems to be increasing in size. What does it look like? So this is again a dermoid, but sometimes they tend to get inflamed, especially in the adolescent age where like we see the inflammation happening in the nevus. Sometimes the same thing can happen in the dermoids also, but the clue here is that you can see that white line in front of the lesion, which tells us that this is something which is very chronic. There is fat deposition here, and this is again a limbal dermoid with some amount of surface inflammation. Rarely they can be inflamed. So again, if cosmesis is a concern, one of the way to go about we excise any other dermoid before you, and if there is a deeper extension of the cornea, ensure that post-operatively is cosmetically little better. Patient excision with tattooing of the area where the corneal extent of the lesion was there, and the scar is relatively less visible here. So other important thing to recognize is that all these complex choriostomas, sometimes they can be bilateral, can be associated with something known as epibulbar linear nevus sebaceous syndrome, because those have implication beyond the eye. There can be systemic malignancies which can be associated with those syndromes, and we need to identify these syndromes, counsel the family, do the screening if required. This was a young gentleman, comes with a medial ptosis, medial droop, which has been there for a long time, increasing in size. What should be your next step of examination? There is a subtle fullness in the medial eyelid. So you evert the eyelid. This is what you see when you evert the eyelid. So what is your diagnosis? We have gone through all of these cases in the first presentation. What does it look like? This is the tarsal conjunctiva. So this was again a complex choriostoma. So it's not necessary that all complex choriostomas that we see will be in the bulbar conjunctiva. Some of them can involve the tarsal conjunctiva also. And a clue to the diagnosis could be, of course, the appearance gives a clue, but also a small subtle coloboma which can be there in the eyelid can give a subtle clue to the diagnosis. So we know that complex choriostoma can have various components of tissue. There can be cartilage, bone, lacrimal gland, many other tissue, fat predominantly. So is there a way to know which lesion will have more component of particular type of tissue? So histopath is a definitive diagnosis, but sometimes looking at the lesion, if it looks predominantly yellowish color, then we are looking at maybe epidermal or adnexal component with fat. If it is predominantly lacrimal gland component, like in the second patient, it looks more pinkish, reddish. If it is cartilage predominantly, sometimes the appearance can be a little bluish. So just a kind of broad algorithm, but of course histopath is required. Dr. Feroz has shown these pictures beautifully. These are the pharyngeal conjunctival retention cyst, implantation cyst, right? This was a young boy, I think 1 or 2 year old, progressively increasing bluish cystic swelling on the bulbar conjunctiva next to the limbus since birth. So what do you think it could be? So it's not that all conjunctival implantation or retention cysts, which are present since early childhood or congenital, are always in the fornix. Sometimes they can involve the bulbar conjunctiva. So what are you going to do for this patient before you plan any surgical excision? UBM is a must because these lesions, since they're present since birth on the bulbar conjunctiva, can cause some amount of pressure effect and thinning of the underlying sclera. Like we see in this patient, there is quite a bit of thinning of the sclera, and if we are not aware of it pre-op and prepare accordingly, we might end up with trouble intraoperatively. So these have already been covered. The vascular lesions, again, has been covered quite extensively. So I will just focus on one lesion. This was a middle-aged gentleman, comes with this history of bleeding, recurrent bleeding. This time it was pretty extensive. So what do you think it is? A vascular malformation. So once the bleeding subsides, we give some symptomatic treatment, maybe some steroid, let the bleeding subsides, and what you see is that lymphangiectasia. So lymphangiectasias are those isolated dilatations of the lymphatic blood vessels, mostly informs the bulbar conjunctiva, and more often than not, they usually will cause ocular surface irritation and other problems. Sometimes little bit of chemosis of the conjunctiva can be the presenting complaint, and rarely they can bleed, especially if they get filled up with blood. So we need to know the underlying lesion and then treat them accordingly. Most of them will be either treated with sclerotherapy, or if it's a very small localized lesion like this, you can go for a surgical excision or even do a cryotherapy. These are again covered. So this also we have, Dr. Feroz has already covered. Young gentleman comes with this ptosis, progressive, and when you evert the eyelid, this is what you see. Any guess what it could be? It's again a very pinkish looking lesion, baby pink sort of lesion. Same what maybe a lymphoproliferative lesion looks like, but he's a young guy, very slowly growing lesion. So this we have already covered. Again, spot diagnosis. Pharyngeal lesion, not the bulbar congenital lesion, but the similar color like the previous patient. Lymphoma, right? Sometimes it can be the conjunctival component or the subconjunctival component could be just the tip of the iceberg. The main lesion could be lying in the orbit. And it is important to recognize this lesion because surgical excision is not the treatment of choice for these lesions. They respond very well to radiation. There are chemotherapy regimes which are available, especially if it's bilateral or there are systemic involvements. We really don't have to chase and try to excise them and cause damage to the normal orbital tissues. So these are conjunctival lymphomas, and we know the typical salmon pink color. It's almost diagnostic even without a biopsy. And treatment is radiation. They respond pretty well if it's an unilateral isolated lesion. So this was a young girl, again a salmon pink color, but she was 6-7 years old. Do you think it still could be lymphoma, or there are other possibilities? It's a little more pinkish. Dermolipoma will be more yellowish. And it's a recent onset, couple of months history as per the parent. She was otherwise okay. She was diagnosed as a conjunctivochalesis. Elsewhere, treated with symptomatic treatment, lubricant, steroids and other thing, did not regress, kept on increasing. We did a biopsy. So what is your diagnosis now?
Round blue cell tumor.
Yes,
Yeah.
acute leukemia. Lymphocytic leukemia sometimes can present in a child with a conjunctival. So a solid chemosis is the clue. So chemosis, which is solid, it's not like, chemosis, which you see in the conjunctiva, is a clue that it could be, especially in a child, either a lymphoma or a lymphocytic leukemia. Pardon? Yeah, orbit, all the workup was done, because if it's a lymphoma, if leukemia is the diagnosis, most of the time the job of the ocular oncologist is to diagnose the lesion. The rest of the treatment and workup is taken care of by the pediatric oncologist. So this Dr. Feroz has again covered cost. I will just finish with these last lesions. So anybody who can pick it up gets a chocolate. What do you think? This was an elderly gentleman, 70-year-old. His complaint was this mass lesion, which was progressively increasing, pinkish, reddish kind of lesion, and a lot of irritation, has been there for a couple of months, and this is the slit lamp appearance. Okay, anything else? It looks pinkish, fleshy. So we did a biopsy, but while we were doing the biopsy, before the biopsy, we decided to go ahead with an UBM because the sclera in that area did not look very healthy. So what do you see? You see what do you see in this area?
Calcification.
There is calcification. So what is the diagnosis now?
Cogan's plaque.
Cogan's plaque. So these are the senile, benign plaques, which are sometimes seen in the elderly patients, elderly individuals at the site of the muscle insertion. Sometimes they can cause a lot of thinning of the sclera with overlying inflammation, which can look like a mass lesion like this. And this was just I don't know if it's playing. Yeah, just a small clip just to show intraoperative. You can see this plaque, the calcified plaque, and look at the underlying thinning of the sclera. The UVA is all visible. So if you try to excise this sclera without a patch graft, probably patient will end up in trouble. So we had to put a scleral patch graft for this patient. So this was all. Thank you very much.
Dr. Seema, excellent presentation. Do you also agree that Cogan's plaque is something which we very commonly see?
Yes, we
And it's
probably don't-
usually thinning, like bluish
Yeah.
thinning. But this has something on top. Is it
So it
inflammation?
was probably an underlying inflammation. The plaque was very thinned out.
Yeah,
There was
that's
lot
the
of
common
inflammation.
presentation. Yeah.
Usually the common presentation, you see a little thinning of the sclera, you see that white plaque,
Yeah, the
but
white
this is
portion.
an overlying inflammation and a lot of granulation tissue on top of
Right.
it.
So you had a histopathology proven
Yes.
that it's inflammation.
Yes.
Inflammation happens in Cogan's
It
plaque
does not.
prob-
I don't know why it happened,
Uh-huh.
but it was there in this patient. So normally so
Okay.
much of thinning probably is also not to the extent that you have to go for.
What was your
removal.
differential diagnosis?
I thought it could be because the gentleman was 70-year-old, so I kept neoplastic
Etiology, and that's why you
etiology as
went
one of
ahead
the
excising
squamous
it,
cell carcinoma as an etiology. That's the reason we went ahead with an biopsy.
Right, yeah. Thank you so much.
So dermolipoma is something like you don't have to go for a complete excision because it's a cosmetic concern. So the part which is visible within the palpebral aperture, we can go for a limited debulking. And depending on the extent of the conjunctival involvement, if there is a need for amniotic membrane grafting, we can do that. Not really. If our clinical diagnosis is dermolipoma and there is no other
Nee.
Yes, we do have couple of patients where there is golden hair with limit dermoid. That's pretty common. Golden has a lot of systemic associations, but most of the time our job is to kind of take care of the ocular surface, and if there is any syndromic association, the patient goes to the kind of either a genetic counselor for rest of the counseling and the physician for the systemic evaluation.
Can we?
Can you provide a hand mic, please?
Can we discuss a little later because we have 2 more presentations
So,
and keynote.
Right,
So there
Yes,
are a lot of
we do agree,
association.
and
We'd be
thank
very
you
happy
so
to
much.
listen to you.
Thanks.
Maybe towards the end after the kind of
Yeah,
all the talks
absolutely,
over.
yeah.
Thank you very much.
Then we have a keynote as well, right? Is Rohit here? Okay.
And I'm
great.
sure Dr. Santosh is going to show the management,
No,
surgical
I'll
management.
do it very quickly. We have
dermolipoma.
little time left.
Thank
I'll
you.
be talking about the management of ocular surface tumors as a group. So when you have a tumor, it could be a malignant tumor or a benign tumor, and since at least 40 to 50% of ocular surface tumors happen to be malignant, you have to combine your surgical skills with excellent oncological principles to optimize the outcome. Now, at the outset, let me enumerate what are the oncological principles that you actually need to take care of. One is to accurately determine the diagnosis and extent. If you diagnose a malignant lesion as a benign lesion clinically, obviously you'll be short of your excision. Not to use topical therapy when you're not sure of the diagnosis. If something looks like OSSN and you're not sure of it, then don't use topical therapy, and don't use topical therapy unless you have determined the depth of the lesion. If the lesion has already involved the sclera or corneal stroma, topical therapy will not work. Whenever you take care of the tumor by surgical excision, you have to take care of the edge and base clearance. Base clearance is more important than edge clearance because that's something subtle that you're leaving behind, which will result in local tumor recurrence, not just on the surface, but intraocular as well. Always give due weightage to histopathology and provide histopathology guided adjuvant therapy. Screen for regional lymph nodes, which is very important if you're looking at a patient with melanoma, and for patients with lymphoma, obviously systemic evaluation, and provide target therapy wherever required. So imaging is mandatory in ocular surface tumors, not just to diagnose a nevus from a melanoma, which I'm not going to elaborate upon, but it is more important to determine the depth of the lesion. For example, in this particular lesion, the diagnosis is obvious, but you're not very sure of the depth because these lesions tend to be hyperreflective and there is some amount of shadowing, but otherwise you can actually know the depth of the lesion, to what extent has it involved the sclera or cornea. Now, about topical therapy, we have chemotherapeutic agents as well as immunotherapeutic agents. Mitomycin and 5-fluorouracil are chemotherapeutic agents, whereas interferon is the immunotherapy. The dose is listed here. I'm not going to elaborate upon the dose, but we have a minimum response time for each of this. You have to try mitomycin for at least 1 cycle, 5-FU for 1 cycle, and interferon for 6 weeks before you declare that the patient is not responding to treatment. And the maximum duration of treatment is also there, beyond which if you continue, the patient will have limbal stem cell deficiency and corneal epithelial problems. When you talk of immunotherapy, interferon, you have immunotherapy, immunoreduction, and immunomodulation. Therapy is to cure, reduction is to reduce, modulation is to modulate the ocular surface so that new tumors don't crop up. Small tumors can be taken care of by a 6 to 3 months treatment with interferon. This was a small recurrent tumor, again resolved with interferon. Corneal OSSN is a standard indication for topical therapy. This is a patient where the biopsy was done here by a cornea specialist. That's the exact area where there's a residual corneal scar. Rest of the treatment was done with topical therapy. So if you have a corneal OSSN, if you try to excise it, you may leave behind a subtle corneal scar in the pupillary axis, thus precluding good vision. OSSN, unfortunate situation where patient with xeroderma can have OSSN at the graft-host junction, which is very delicate. This patient had a valuable third graft. 2 of his prior grafts had failed, and you cannot take risk by surgically excising these lesions. These are best treated with topical therapy. Tumors which occupy more than 6 or 7 clock hours of the limbus can cause limbal stem cell deficiency if you try to excise them, although you can, to a certain extent, take care of it by primary limbal stem cell transplantation, but still it's a good idea to use topical therapy. Diffuse flat tumors, tumors which are placoid, are best treated with topical therapy, whereas these tall boy lesions are best treated by surgical excision. So you have to take care of the configuration of the lesion as well. This was treated with topical interferon for several weeks and it resolved. Immunoreduction is a principle where a large surface tumor can be reduced to a small lesion. That's because what is left would be the invasive component of squamous cell carcinoma. What goes away is the dysplasia carcinoma in situ component. So when you're left with this, be sure that that's the invasive component or squamous cell carcinoma component of OSSN, which you must surgically excise. Immunomodulation is for patients with xeroderma pigmentosum or HIV patients who tend to recur or have new lesions. Now, diffuse OSSN can be taken care of by injection interferon. This is very good for eye salvage, where otherwise you would do orbital exentration. At least half of them you can prevent doing orbital exentration if you were to give injection interferon along with aggressive topical interferon. When diagnosis is in doubt, such as vegetoid sebaceous gland carcinoma, don't be aggressive with topical therapy. You have to establish the diagnosis first. When you're not sure of the depth, again, no topical therapy. When you're not sure of patient compliance, surgery is the best treatment. When you talk about surgery, there are three issues here: excision with edge and base clearance, alcohol-assisted keratoepitheliectomy for the corneal epithelial component, and excision edge cryotherapy gives you an additional benefit of about 3 to 4 millimeter. Edge is very easy to determine. When you stain the tumor with rose bengal and take care of the subtle thickness of the conjunctiva beyond the clinically evident lesion, which you can only note by slit lamp evaluation, edge is crystal clear. But what about the base? You cannot determine base on slit lamp evaluation because you simply cannot see the base, and what is required is anterior segment imaging, either OCT or UBM, which will tell you that this patient has full thickness corneal stromal involvement already, so excision is not going to help. This patient will need either a penetrating keratoplasty or brachytherapy. It's a good idea. See how beautifully my mentor draws Carol Shields' diagram, which I have preserved over 25 years. This is how she maps out conjunctival melanoma so beautifully. All lesions marked, and this is what we take to operating theater. Right now we use digital photographs, but nothing short of hand-drawn pictures of this sort. Of course, excision is very simple, where you map out the lesion, go 3 to 4 millimeter beyond it, excise it, whatever instrument that you prefer. Monopolar RF, bipolar RF are very valuable in terms of controlling or having hemostasis at the time of surgery. But if you don't have access to it, scissors and blade would simply do. That's not a problem. But once you excise it, you have to use certain oncological principle. Always hold the edge of the conjunctiva with non-tooth forceps if possible. Don't hold the tumor ever. Reach the limbus from the conjunctival side. Cauterize the feeder blood vessels at the limbus. Apply absolute alcohol to the leading edge of the tumor. 3 to 4 millimeter of the epithelium should be de-epithelialized using absolute alcohol. Once that is done, the corneal epithelium is denatured and it also scrolls back beautifully towards the limbus. So you're reaching the limbus from the corneal side as well. So you reach the limbus from the conjunctival side already. Now you're reaching the limbus from the corneal side. You have to finally do lumpectomy because OSSN is a tumor of the limbal stem cells. So once you've reached the limbus from the corneal side, you start from one edge of the tumor, perhaps the superior or the inferior edge depending on your ergonomics, and you excise the tumor off the limbus. Then you do then you do excision edge cryotherapy and repair the ocular surface with amniotic membrane. These patients tend to do well. But what about patients who are beyond surgery, patients who have scleral invasion? We were enucleating them, extended enucleation of course, or exenterating them. No longer so, we can take care of them by using plaque brachytherapy. Mainly because the scleral or the intraocular component can be easily treated with about 6,000 centigrade of ruthenium plaque. This is how nice results are. Sclera does not melt even with high dose of radiation. This is secondary plaque brachytherapy after excision, but if you have a tectonically unstable cornea which is already showing stromal melt or weak sclera, you cannot try to excise them without leaving a tectonic defect, which is impossible to repair. So you do primary plaque brachytherapy, which also works well. Melanoma, of course, plaque brachytherapy is useful as an adjuvant measure for the scleral component. Large extensive melanomas this patient had about 270 degree of melanoma, multiple recurrences, small intraocular component. You can see the ciliary processes there. That's the intraocular component of melanoma that could be taken care of by plaque brachytherapy with good outcome. Plaque has about 90% success. This has recently been published. Patients with intraocular extension, young patients who want eye salvage, we have stereotactic radiation. This patient had choroidal involvement as well as exudative retinal detachment, completely settled following stereotactic radiation. That's MRI guided stereotactic radiation that we delivered. You can see nice results. Not all patients respond this beautifully, but this is one exceptional case where we wanted to do eye salvage because of the request of the patient. These patients need orbital exenteration. Adjuvant therapy is based on histopathology. Resection H positivity only displays your carcinoma in situ. If you have already done cryotherapy, nothing to do, simply observe. If you haven't done cryotherapy, then you have to do topical adjuvant chemotherapy or immunotherapy. Resection H positive with invasive squamous cell carcinoma, medico-legally you are bound to do re-excision. There is no escaping that. Resection base positivity, localized cryotherapy. Resection base positivity, diffuse plaque brachytherapy. Margins and base negative, but the patient is prone to recurrence, then you do immunomodulation. Lymphoid tumors, of course, incisional biopsy or complete excision is mandatory, followed by rest of the treatment. For lymphangioma, bleomycin or vaporization with resurfacing. Target therapy mainly for lymphomas. You can use localized target therapy such as perilesional rituximab, which works for conjunctival malt lymphoma specifically. For conjunctival melanoma, depending on the mutational spectrum, we have many drugs, pembrolizumab, nivolumab, etc. This patient has regional lymph node metastasis for which he got approval for nivolumab, and you can see the disappearance of the conjunctival lesions as well. So ocular surface tumors, if you do these, manage these with protocols, then you have less than 5% recurrence rate, less than 2% of regional lymph node metastasis. If you don't use protocol-based technique, then you have a much higher chance of local tumor recurrence and regional metastasis. So simple application of oncological principles can actually help improve the prognosis of these tumors, especially in terms of local tumor recurrence and also systemic metastasis. Thank you so much.
You're able to see? Sorry? क्या मैं slide पर? Slide move हो रही है.
SH. Nowadays, what about line X and X knife? Because we are using cyber knife nowadays. So going through a lot of tedious works, it's all easy to...
Correct. Easy but expensive and causes...
No, not at all.
No, not in a government hospital, but otherwise it's expensive. But the problem with that is that, you know, you have corneal stromal damage and also the patient has to go through a lengthy treatment process, whereas surgery is 15-minute job and obviously it is much better in terms of...
Cyber knife is something, you know, it's a single, there are two principles. Either it totally cures, removes the tumor or cures, right? So, single sitting.
You're talking about stereotactic radiosurgery?
Yeah.
Stereotactic radiosurgery is
yeah.
that is true. That is what was used
types.
that is what was used in that patient with intraocular
That's what I'm
extension.
saying. That you used this cyber knife, it's just 75,000 per sitting.
Whereas surgery is 5,000.
So, thank you everyone for covering all the important topics, and I think we'll take this as just a post-IC test for all, because mostly all the topics have been covered. And who are the lucky ones who have the hand mics over there? Can you please raise your hand? There are 3 hand mics that have been given out.
And Rolika will be distributing prizes to the right answers.
Yes, I will. Where are the hand mics? Can you please help with the hand mics, because it's an interactive session.
Yeah, so the plan is to do a session and then kind of, yes, like a post. What
And
you have.
otherwise you can volunteer
Rolika.
and be there. Yes. So you can just keep telling the spotter part because we have less time. So just go on and say the answer. So
The first prize is an iPad.
yeah, right. Okay, so can you take a guess as to what the lesion is going to be? So no case presentation over here, and Ruju wants to do something. What do you want to do? Perfect. So you would like to avert or look out for something. Now, what do you say the answer is going to be? It has to be a real quick spotter part. Dr. Anju is holding the mic. She has to answer.
A lymphoma.
Okay, so lymphoma is one of the differentials. Anybody else?
But Rolika, this is a superolateral fornical conjunctiva.
That's correct.
But the fullness is mostly in the medial. And there is the skin also which looks abnormal. Yeah. So that is a superolateral conch.
Right. That's correct.
Patient has 2 things.
So, sorry? So I'm finding this interesting. So there's xanthogranuloma on the table. There's lymphoma on the table. Anybody else?
Dermalipoma.
Sorry, Dr. Honavar does. Okay, Dr. Honavar can also answer dermalipoma. Anything else?
When was the presentation? He looks old.
Yes, so he presented, it's a chronic presentation.
Like as a child?
No. He
As
is
an adult?
As an adult.
Dr. Honavar, dermalipoma cannot be.
Must have not seen it. I don't
So
remember this.
interestingly, I twisted the tail a little bit. So this is a case of cost. So the whole point of putting this case right there is that the presenters have presented very well about dermalipoma presentation. And as Dr. Honavar said, there are 2 components, and Dr. Feroz has very nicely mentioned that there is a conjunctival component and it looks like there is a dermalipoma there. Do not get confused. The answer could be cost, and the only way to know about the answer is histopathology. So there's nothing much that you can do. So go ahead and excise the lesion and you will have an answer. So another spotter right there. Anybody? It's a quick question.
Close
Anyone can take it. Okay, so I can give a larger picture right there.
up. Cost.
Cost on Excel.
So now the panel has got me, so they know that what am I looking for. And my purpose of putting it across is that you must do OCT because that differentiates it from the squamous cell carcinoma. And you proceed with a clear excision, and again, histopathology reveals the answer. The next question Dr. Honavar is not allowed to answer. So what do you think this patient has?
Complex choristoma.
Okay, so this is a complex choristoma. I agree on that. Anything else that you would like to look for? And Ruju cannot answer this question too. Raise the eyelid. Okay, anything else that you would like to examine?
Ears.
Okay, what are we looking at for the
The
ears?
auricular area.
Okay, then what else are we looking at?
The head,
Bald
the
patches.
forehead. The head, the forehead,
So
face.
this is a little extension, right? So you see a pigmented mark across the face, right? And the bilateral presentation. And then again, the forehead, as Dr. Feroz mentioned, irregular margins over the eyelid, and these lesions are pink to brown. This is a case of nevus sebaceous of Yaddison, and you must look out for preauricular lymph nodes is also the correct answer. You will see that in golden heart syndrome, but over here she had large geographical areas of patches and bald patches of alopecia, and he was not allowed to answer. but yes. And of course, you should look out for that these can give rise to sebaceous cell carcinoma or even basal cell carcinoma. So be very careful and follow up these patients, preferably excise these lesions as soon as you can. So very easy, quick question. The panel cannot answer. It's a very easy spotter.
Age of the patient for the delegates.
Age of the patient is around 65.
Onset.
This is also a chronic onset. Yes, OSSN with orbital extension. Okay, pardon me for the next picture. I'm just going to skip that part. So this is an elevated nodular ulcerative or flat ulcerative lesion. They can present as orbital invasion you must look for, and they metastasize to the regional lymph nodes. Now another one which Dr. Vikas Menon has mentioned. I'm giving a good hint. This is a very easy one.
Onset. Age of the patient.
So I would love to give the age and the onsets, but that's where the trick part comes in.
It's easy for
Okay, so this is a 45-year-old, and the lesion has grown slowly over the years, say for past 6-7 years. Sorry, I cannot hear you. Pigmented SCC, yes, this is exactly why I put it across. Actually, this is a case of malignant melanoma, and Dr. Vikas Menon had actually mentioned it. And yes, the component does look like it is pigmented, it's OSSN, and then there is a pigmented part of it. But again, the answer will come out by histopathology, and you must make sure that you do a keratoepithelectomy over here and proceed with histopathology. A quick spotter over here. Ruju is excited. Go ahead, Ruju. Easy one.
Pyogenic granuloma.
I thought you would say that, so of course, but these are all tricky ones. This is actually a conjunctival papilloma. It's just a small papilloma. If you look very closely, there you will see those loops, and those are the giveaway for a conjunctival papilloma. I'll try. So I've been asked to give the age for all. So this is a patient of 35-year-old male, and who presented with this lesion. He doesn't remember since when has it been there, but has slowly grown over the time. Nevus. So why would you say it would be a nevus? Because yes, you see the cystic spaces. Even though there's a feeder vessel right there, you see cystic spaces. And this is a 14-year-old who presented with the lesion which has been similarly growing.
Choroidal melanoma with PAM.
So I do see features of PAM in the inferior part, but I wouldn't say a choroidal melanoma, I would say conjunctival melanoma.
Conjunctival melanoma.
Right, and there's a feeder vessel there, there's a corneal component. The child is only 14 years old, but is doing well, and even if they present with systemic involvement, you can give immunotherapy, and it can be taken care of. So mostly dark pigmented flat lesion, elevated feeder vessel, intrinsic vascularity, scleral fixity, corneal involvement, always look out for that. Another case over here, and my question over here is not what the diagnosis is. This is a patient with a 48-year-old who's presented with this component on the temporal side, has been there for a very long time, and now the patient has developed new lesions in a speckled manner. So what would you like to do? So I think we have flipping fans over here. So absolutely right. We would like to flip the lid, and you would like to look out for what is underneath. And the purpose is that you must look out for different spots of melanoma. So in any case with melanoma, it might have focal spread, right? And we must treat it. And small lesions which are like really tiny foci, they can be taken care of by cryotherapy as well, and they respond very well. So the patient was treated with plaque brachytherapy, excellent response. The tiny spots were taken care of by cryotherapy, all good. I think I would skip this one because I think it has been covered twice and thrice. You want to tell me what the answer is? Okay, fine. So there's no point of that. A trick question over here. So this is a 42-year-old male who's had this lesion for the past, say, 2 years, and it has not grown much. What would you think the answer is? Okay, Dr. Ruju, you were supposed to answer now.
Adult onset capillary hemangioma.
What did you say?
Adult onset capillary hemangioma.
Okay, fine. I give her that one. This is a case with adult onset capillary hemangioma, and they present, you can confused with pyogenic granuloma. A granuloma and an adult onset or acquired capillary hemangioma are not the same. They're not even lobular. They are absolutely different entities which are to be proven by histopathology only. However, this is a pyogenic granuloma. The more elevated, the more pinkish, and of course you can incite a history. This will be, due to a reason, maybe a rubbing of the eyelid, and you will be able to incite that. Another easy one which I'm going to let go. You can give me the answer quickly. Absolutely. So this one, I have just 2 more left. Absolutely right. So that was, you will see widening of eyelid margin, loss of eyelashes, abnormal vascularity, and that was a pagetoid spread. So thank you everyone, and thanks to the panel for educating us with the wonderful cases.
Thank you, Rolika. It was great coming to the end of this instruction course, and I hope it was useful. We had a lot of interaction, and we have a lot of delegates in this hall. Now, at the end, I would like to invite our honorable guest, Dr. Rohit Saiju, who is a keynote speaker today with us, and he's gonna tell us what is my next step, a management to an acid burn victim. Dr. Rohit Saiju is a very renowned oculoplastic surgeon who does a lot of community eye health in Nepal. He's from Tilganga Eye Hospital. We often learn a lot from him, and he's a precious guest speaker representing Nepal, and he's gonna share his experience with the acid burn victim. Over to you, Dr. Saiju, and it's a pleasure and honor for us to have you here today as a keynote speaker.
Thank you very much, Dr. Fairouz, for introduction. Actually, I learned from you all today a lot. The learning process is always bilateral and will be continued throughout the life. I would like to thank you, Dr. Santosh Honavar, and the panel for inviting me. And I am very much privileged to be with you and make a small talk on the other direction of today's instruction course. This is not the malignant, and this is on the acid-borne case. So talk on the management to an acid-borne victim with contracted socket, how I would manage. I do not have any conflict of interest to disclose. So chemical bond, we know this is a very danger, and acid and alkali are frequently cause for the ocular emergency in the household accident as well as in the factory-based accident, and can cause severe damage to the eyelid, eyeball itself, and sometimes the vision loss. As we know that the acids, when keep contact with the tissue, will denature the protein and make a very thick barrier for the progression. So in comparatively, it is better prognostic in compared to alkali. Alkali will saponify the tissue, and it will continuously progress to the deeper tissue. There are different types of bonds, including the thermal bonds, chemical bond, electrical and radiation bond. The severity of bond is determined by the contact time with the chemical, the concentration of the chemical, and the type of the insult, like it is the what type of and the things. So bond is classified according to involvement of the tissue as a first degree, second degree, and third degree. If it involves only the epidermis, known as a first degree. If it involves epidermis and dermis, second. And if involved all the layer of the skin, including the subdermal subcutaneous tissue, it is a third degree. So here are some of the chemicals which come to the contact in our profession, our household activities. The sulfuric acid and the hydrochloric acids are the most commonly found chemicals causing the bonds in the different profession. So management of the acid bonds is very crucial. You should do immediately as patient come to you, wash out with the copious prolonged irrigation or wash with the saline or ringer glycate. If you don't have those, then the drinking water is okay. So try to wash as long as 30 minutes or more. And further, you put the litmus paper if you have, especially take attention at the furnaces, upper and lower furnaces, where the particles of the chemical can lodge for a long time and will continue destructive procedure. So if you are happy with the neutralized litmus paper reading, then it's okay. So further, serial debridement, control the infection topically and systemic with the broad spectrum antibiotic, serial dressing, lateral scar management, and multiple surgery will be followed. So what is the contractile socket? A socket where the upper and lower furnaces are shallow, or the volume or surface deficit not allowed the processes fitting well in that socket. So here is the classification of the contractile socket. Grade 0 is a normal socket. Grade 1 is where the inferior fornix is involved or shallow. This is the fornix where the prosthesis is dependently retained there. Should be a very properly formed. It is important to be a good inferior fornix. Grade 2 is superior and inferior fornix shallowing. Grade 3 is all the lateral and medial fornices also shallowing. Grade 4 where the palpebral fissure, horizontal palpebral fissure is narrowing. And grade 5 is where the recurrent of the contractile socket after serial surgery. So causes of the contractile socket could be the congenital, post-trauma, and post-ocular or orbital tumor treatment like in retinoblastoma with the external beam radiotherapy, though nowadays it is very rarely used, or not orbitally implanted after the surgery and the poorly fitted prosthesis making irritation and growing the granulation tissue. So when patient come to you, our job to evaluate properly for the surface, volume and other relevant things. Look at the vascularity of the socket, involvement with the muscle, fornices, especially the lower fornices is important, and associate injury with the soft tissue as well as bone trauma. So what are the materials we do use for the socket reconstruction? Mucous membrane graft, which is most commonly we use to make the socket healthy and wider, dermis fat graft, split skin graft, and temporalis fascia. And also the flaps like the cheek rotation flaps, putting the implant, and combination of the above mentioned things. So mucous membrane graft is the most common graft where the contractile socket is reconstructed, and it adds the surface area, not the volume, and it's more vascular in compared to the dermis fat graft, especially very useful where the acid bonds cases are land up with you. So buccal mucosa is another mucosal donor site, which is very good for the large area is needed, and both sides of the buccal mucosa can be harvested when you needed these. But you have to take care of the one of the duct of the salivary gland, parotid gland is a stension duct. We don't want to make the cut that and making the sclerosing effect on that. And the labial or the lip mucosa is another site for the mucosal graft, where you need the small amount of mucosa is needed, and care should be taken around the frenulum where other salivary glands opening are occurred there. And always take the graft is a little bit larger, about 20 to 30%, because there is always tendency to shrinkage of those graft after grafting. So dermis fat graft is very useful graft, and I'm a fan of harvesting and putting this graft in most of the cases where the surface and volume augmentation is needed. It is a tissue of the fat overlying with the dermis, and the dermis side is always putting the outside, and fat will put inside the socket. Temporalis muscle flap is another flap where you need the vascularity and surface, no volume. It's very good. It is a pedicle flap along with the superficial temporal artery branch will promise the vascularity of your socket. It's ideal for the poor vascularized socket, like the acid-borne cases. These are the very good, like in post-radiotherapy, post-local chemotherapy depot in the ovid, or the exenteric socket can be repaired with this type of graft. Split skin graft is another type of graft, very useful when you need the large surface recovery or repair, but not the volume. And split skin graft can be harvested from the thigh or inner aspect of the arm. So this is the case come to me with the domestic violence. This is the acid-borne victim, and 1 year ago, prior to the second surgery, the split thickness skin graft was done with the dermis fat graft, and after the period of the time, the graft was shrinked, and the adhesion of the conjunctival tissue as well as the skin is here. You see clearly the symblepharon and ankyloblepharon has occurred. So this is a recurrent contracted socket, and this is a small video is showing that how I repair this contracted socket. Initially, I just making the mark on the center of the pulpal fissure. It's along 10 millimeter from the eyelid margin, and made an incision with the radiofrequency cautery, and then submucosal dissection is performing here, and you see the previous dermis fat graft is there, and it is quite healthy look and viable. So that's why volume is not a deal here. The main problem is the lack of fornices and lack of the good surface to well fit the prosthesis, you see. And I just put the conformer of the appropriate side. It is residing very well. So I would like to repair the socket with infiltration with the saline is given, which will give the hydrodissection and easy to dissect, and as well as the hemostasis is occurred. I think can use the xylocaine with the epinephrine combination, also good alternative for the saline, and cut the mucosa with the knife along the previously marked lines, and then the subconjunctival dissection, submucosal dissection is performed here, and you secure the hemostasis nicely with the bipolar cautery and put in the saline solution, the graft, and close the graft with the 6-0 catgut or 6-0 vicryl nicely. And some of the surgeons are keep open the wound without repairing that and put the mucous membrane, the amniotic membrane overlay this. So here the trimming the submucosal tissue to make the smooth and even surface. Then you just put over the previously grafted dermis fat graft, the mucosa, and then sutures starting from the four corners, medial, lateral, superior, inferior, and in between interrupted sutures are put there very nicely. And then the fornix forming sutures are kept. So 2 in the superior and 2 in the inferior. You can put 1 or 2 more superiorly and inferiorly, but I usually happy with the 2 fornix forming suture with the 4-0 vicryl suture, keeping the bolster over the skin, and I then do the sutural tarsorrhaphy, keep for 4 to 6 weeks. By the time, this is the post-operative picture. You see here, the fornix has formed well, and conformer is residing inside very nicely, and frost sutures are there, and healing donor side with the mucous membrane graft is also doing well. In summary, the acid-borne contracted socket is one of the very difficult procedure to repair or to tackle, and we need the multiple procedure to be done at the same or serial sitting, like the fornix forming, augmenting the volume, augmenting the surface at the same time, or the in subsequent sitting, and can use the antimetabolites like 5-FU or MMC to prevent the constriction or contracture of the ease of the mucous membrane graft, or perioperative steroid also advised to reduce the inflammation, so scar or fibrotic action can be reduced. Then like the 30 milligram of the prednisolone over the 4 to 6 weeks tapering dose can be advised. So this is the teamwork. Altogether we have to deal for our patient, and our aim is always to make a comfortable socket where the mobile prosthesis can be well fitted and the patient can run a good quality of life. Thank you very much.
Thank you, Rohit. Thank you very much. Thank you all for being here. I think it will be useful for you if you incorporate some of the principles that we discussed in your immediate clinical practice. Thank you for being here.
Over to you, Dr. Rohit and team. And it's going to be a very interesting topic next. It's about cells. Thank you.